Hi, this is Tarek Sami and Manos Brilakis, and this is case 145 for the Manual of Percutaneous Coronary Interventions. This was a gentleman with a previous aortic valve replacement who presented with non-ST elevation myocardial infarction. He also had a previous stent into the circumflex. And there are two interesting findings on this very first injection of contrast in the left main. The first one is that there appears to be an ostial left main lesion, with the catheter being non-coaxial to the vessel. And the second one is that we have TIMI1 flow distal to the previous stent, which is suggesting of possible stent thrombosis, especially in the setting of non-ST elevation myocardial infarction. At this point, the patient developed significant hypotension. And we did have a concern that we compromised the left main, or there was a left main dissection. We therefore delivered a stent into the left main, trying to bring it back all the way to the left main ostium. After the stent was placed, the patient's hemodynamics improved. We did intravascular ultrasound that demonstrated some plaque in the left main, but no significant residual stenosis and TIMI3 flow into the vessel. We then wanted to exclude that the patient had aortic dissection, because sometimes aortic dissection can mimic as native coronary disease, so we performed an emergency transesophageal echocardiogram. However, this did not demonstrate an aortic dissection. As a result, we proceeded with our case. We used a guide catheter extension to better engage the vessel and obtain higher quality images, so we can see the occlusion of the previously placed circumflex stent. We were able to wire through, perform balloon angioplasty, and that restored the TIMI3 flow down the vessel. And then we decided to stent with an additional 3.5 by 23 millimeter Zions drug-eluting stent. And that improved the flow. However, it also revealed that there was an obtuse marginal branch that we had not previously seen, but now it seemed to be filling with the TIMI2 flow. What to do to improve the flow into this branch? Advance a wire in the branch and then trying to find the cause. So we did use a Sion black guide wire that was easily advanced into that obtuse marginal branch. We then administered intracoronary vasodilator, specifically nicardipine, as well as 3,000 micrograms or 3 milligrams of adenosine through the Sasuke dual-lumen microcatheter, and that actually restored TIMI3 flow into both the circumflex as well as the obtuse marginal branch. And the patient did pretty well. So what are the lessons from this case? The first one is whether acute hypotension in a patient who appears to have significant left main disease may be due to dissection of the left main. If this seems to be the cause, then stenting of the left main can provide the solution. But in ostial left main lesions, it is also important in selected cases to rule out aortic dissection that can sometimes masquerade as left main disease. Here we had a patient with stent thrombosis. Another stent was placed. We actually did transvascular ultrasound that did not show any anter-expansion of the previous stent. But after placing the stent, there was transiently slow flow. That was treated by using vasodilators through the microcatheter, specifically nicardipine and adenosine, providing a nice final result with TIMI3 flow. Thank you.